Hello, my name is Kiera Terrence. I'm a nursing student at Heartland Healthcare Center, and I'm going to present a patient to you. Patient is a 62-year-old single Caucasian male. He previously worked as the manager of a furniture store before his declining health forced him to stop working. At his most recent vital signs check, his blood pressure was 100/65, heart rate was 60 beats per minute, respiratory rate was 12 breaths per minute, and temperature was 96 degrees Fahrenheit. Patient presented with the right lower lobe pneumonia and altered mental status. He reported having increased congestion, cough, and producing a greenish-yellow sputum. He also reported having a decreased appetite and extreme shortness of breath, making his activities of daily living difficult because every task felt like a chore. Upon entering the care facility in August, the patient was overweight, but as his conditions worsened, breathing and swallowing became too difficult, resulting in a tracheostomy and peg tube being inserted for feeding and 150-pound weight loss. His weight dropped from 317 pounds at the beginning of his stay to a current weight of 203 pounds. In addition to his current condition, the patient also has a heart murmur resulting from his coronary artery disease and cardiomyopathy. This causes mitral regurgitation and aortic stenosis. These pre-existing conditions may have contributed to his current diagnosis of pneumonia. A review and physical assessment of the respiratory and cardiovascular systems were completed. A review of the respiratory system with the patient revealed that he did have some shortness of breath, but no history of bronchitis or asthma. And he said that this was his first incidence of pneumonia. He reported having increased cough with the greenish-yellow sputum production, but denied having frequent upper respiratory infections. He also reported to have no pain or wheezing with breathing. During the physical assessment of the respiratory system, it was found that the patient did seem to be a bit distressed because of his shortness of breath. He was bilateral, and his AP diameter appeared to be 2:1. There were also no injuries. His trachea was unpalpable due to the tracheostomy. There was decreased expansion on his right side and increased tactile firmness as a result of his consolidated lung tissue. But there were no broken ribs or masses posteriorly. During auscultation, breath sounds were normal anteriorly and laterally on the left side, but posteriorly and on the right lateral side, crackles could be heard. When testing for egophony, bronchophony, and whispered pectoriloquy, sounds were normal on the left side but abnormal on the right side. During review of the cardiovascular system, it was found that the patient didn't experience any pain, arm, or jaw numbness, but he recalled having history of coronary artery disease and heart murmurs. He also said that he fatigued quickly and didn't have much energy throughout the day. He cannot walk because he is bedridden and can lie flat but not for a long period of time, usually requiring 1 or 2 pillows to hold him up. Upon inspection of the 5 key heart areas, no heaves or lifts were found. When palpating the 5 key areas, no lifts or thrills were felt and the PMI percussed normally. During auscultation, clicks were heard over the aortic area as a result of the patient's aortic valve replacement, and his S1 and S2 sounds were present over pulmonic Erb's point and tricuspid regions, but irregular. Sounds over the mitral area seemed normal when listening with the diaphragm, but a murmur could be heard when listening with the bell of the stethoscope. Based on the history of this patient, it seemed that neurological and musculoskeletal systems were also important to assess. According to a study published in the Journals of Gerontology, it is important to assess the neurological system in patients with pneumonia because altered mental status is a factor found to be a predictor of mortality in elderly patients with pneumonia. Because the patient presented with altered mental status, we will want to be sure that his condition is not worsening and his altered mental status is not a sign of any other diseases or infections. According to Johns Hopkins Medicine, joint pain and risk for osteoarthritis is strongly associated with body weight, and being just 10 pounds overweight increases the force put on the knees by 30 to 60 pounds with each step. As aforementioned, before becoming ill and losing weight, the patient weighed 317 pounds and had been overweight for most of his adult life. This likely put stress on his weight-bearing joints, especially the knees. Therefore, it is also important to assess the musculoskeletal function of this patient. Here you can see my references.